Should be the recording started.
Okay, thank you very much. Okay, welcome everyone to the session of the Integration Joint Board. I rule that under Standing Order 5.6, online participation has been enabled for this meeting to allow members of the IJB and officers to attend remotely. Members of the local media are also in attendance via. Please note that this meeting is being recorded and will be published online for public access after the meeting. Can all participants online please switch off their cameras and mute microphones when not speaking? And if you need to speak on any point, please use the raise hand function in Teams or indicate your wish to speak by signalling on your camera or taking your microphone off mute. Officers are reminded to follow the protocols that have been separately issued with regard to their participation. And before we start the meeting, can I please ask the committee officer to do a roll call for members of the IJB online to confirm they are present?
Thank you. Mr. Carroll.
Good morning.
We have apologies from Mr. Campbell. Mr. Fraser.
Good morning.
We have apologies from Ms. Haswell, but I believe Mr. Robinson is in attendance.
Yes, good morning.
Thank you. And that's everybody online.
Okay, thank you very much. We will move on to the agenda. And is there any declarations of interest for the public session? No, I'm not seeing any. Okay, if we could move on then please to confirm the minutes of the meeting held on the 28th of October.
Happy to move.
Okay. Is anybody happy to second those minutes?
Happy to second.
Okay, thank you. And then we'll move on to the minutes of the 9th of November. Just there's an error on that page. It's got voting members and it's got Gary Robinson substitute for Colin Marsland. I'm not sure is right.
Well, Mr. Marsland was substituting for Ms. Cornick, and so he was substituting for Mr. Campbell.
Okay, that's fine.
Okay,
so right.
yeah.
I wasn't at the meeting, I just thought it was straight.
Yeah, okay,
that's fine. Okay, are we happy to somebody to move those minutes? Anybody who was here happy to move those minutes?
Sorry, Chair. Yeah, I think was just a point of order on that. I think Gary's substituting for Colin Campbell, who is substituting for Natasha, because Colin Marsland's not a non-executive director. Just wanted to check that, Gary.
Sorry, are you questioning that that's the situation? Because that's as I understood it, but if I'm wrong, then we can note it as an incorrect. But and my understanding that Mr. Marsland is normally substituting for Ms. Cornick.
No,
It'd be Colin Campbell.
yeah, Campbell usually substitutes.
Sorry, is it Marsland?
Yeah, that's what
I do apologise. I do apologise. I did think as I had written Mr. Campbell, so I do take that back. I will make that note.
that's fine.
Campbell, not Marsland.
And is somebody happy to second those?
I'll second that. Thanks, Chair. Lincoln.
Did we have a, sorry, Mr. Carroll, I thought you were moving it. Mr. Fraser, are you available to second?
Yeah, that's fine, yeah.
Okay, super. We got there in the end.
We will get there.
Thank you. Okay, we'll move on to item 1 on our agenda today, and that's appointment of non-voting member to the IJB. And Jan is going to take us through this one.
Yes, thank you, Chair, and good morning, members. This is a straightforward report dealing with an appointment required following the resignation of one of your members, non-voting members, as the Chief Nurse Senior Clinician representative. The board have made an appointment and the Chair has confirmed the nomination of that appointee to you for your confirmation. So in many respects, it's just a straightforward acknowledgement of that, and to welcome Kim Anderson as the non-voting member, now nominated as the Senior Clinician Senior Nurse Representative. I would just also observe before I hand over to you to make that decision that the appointment will last until the 19th of July 2024, when all of the appointments of the non-voting members will come up for review. Thank you.
Thank you very much. Does anybody have any questions on this report? No, no questions. Okay, well, we've been asked to appoint Kim Anderson as non-voting member as the Senior Clinician Senior Nurse. I would just like to take this opportunity to really thank Edna Merry for all her work over the last years that I've been involved in the IJB. We've worked very closely with Edna Merry and we have benefited from her knowledge and wisdom, and I'm sure we'll do the same with Kim. So we're looking forward to working with you, Kim. Does anybody have any further comments? No? So we're happy to make that appointment.
Unanimously approved.
Yeah. Okay, thank you very much. So we'll move on to agenda item 2, which is the financial monitoring report to the 30th of September 2021. And Carol is going to take us through this one.
Okay, thanks, Chair. This is the financial monitoring report for the first 6 months of the financial year up to the 30th of September 21. It's already been to the IJB Audit Committee on the 25th of November, so I'm not going into great detail here. So the IJB Commission services to projected overspend is 3.2 million for the end of March 22. The SIC arm of the budget is projecting a 735,000 overspent. The NHS arm is projecting a 2.5 million overspent, but 1.3 million of that relates to acute services. That's the set aside budget, so that's not directly managed by the Chief Officer. At this stage, the recovery plan is no necessary, as the SIC will work to address the projected overspend and will provide an additional top-up payment if necessary. And the NHS side is a result of locum cost pressures, and it will be covered by an additional payment by NHS Shetland as agreed during the budget setting process. If you look at page 23, Appendix 1, that's a breakdown of forecast by surface area, and that has a summary narrative. It should be self-explanatory on what's causing the variances. The main issues, as we're all well aware of on the NHS arm, is this locum costs in psychiatry, primary care and hospital medical services. The SIC arm of the budget, the main reason for the projected overspend is again agency staff and adult services, adult social work and community care resources. There's also an increased demand for option 1 SDS packages, creating a cost pressure of 326,000. And then there are underachievement of residential income of 300,000, although I think the latest update on that is the income situation is improving. COVID-19 continues to be a massive pressure on the service. I checked that COVID costs for the year is 3.7 million, and at this stage we still expect that to be fully funded by the Scottish Government. So this current forecast is not in line with our medium-term financial plan, but there is work continuing to address this. The NHS Programme Management Office has been extended for another year following a positive trial period, and it's currently looking at primary care transformation. There's a progress report on that later on in the agenda today. On the SIC side, a review is taking place to look at alternative models of recruitment to attract people to hard-to-fill posts. That includes relocation packages, review of job specs and modern apprenticeships, things like that. The aim is to reduce the reliance on high-cost agency staff. Finally, the medium-term financial plan is going to be updated before the start of next financial year, and that will reconsider this ambitious target we currently have a reaching financial balance by 2023. We need to make that more realistic in current circumstances. So happy to take any questions on that report. Thanks.
Thanks very much, Carol. Any questions? I'll maybe start. I'll ask a question and give people a chance to put their hands up. You spoke about the medium-term financial plan coming back to us in the new year and the need to look at our ability to reach that sustainability target. I know it says in here that the medium-term financial plan requires us to make in the region of 8% savings each year to allow us to be sustainable by 2026. Is this just another unachievable target? Because we keep seeing that there's huge growth in a lot of these areas that we're not managing to tackle how we do things differently, because we're having to keep doing things the way we are doing them, because we have to provide these services. And I have no doubt that that's the right thing to do. But if we can't make that shift to doing things differently, and some of that might need having to spend extra money on them to double run services while we make those shifts, is that to, 2026 any more realistic than 2023? Sorry, Carl, not probably the easiest question to answer.
No, you're right, Emma, and I think that the plan for updating the medium-term financial plan is to kind of rely on this good work that's been done this year, kind of wraparound planning, and I think the improvement in the whole planning cycle this year should result in more robust financial plans to support each service, and that kind of shows us what finance we need to deliver our required outcomes. And if you have that, that's a good starting position to tell funding partners or even government how much money we need to fund this service. And that maybe changes the approach for the medium-term financial plan, maybe more in line with what finances do we need out of next financial year to deliver our services, and that becomes a negotiation document rather as a document saying we need to mark 8% savings each year, because that, as we all know, is basically really, really difficult, especially with the current pandemic. And as you say, increasing demographics and things like that, there's too much pressure on the system for that to be realistic.
Okay, thank you. And John?
Thank you, Emma. With the National Care Service looming over us and that being an unknown quantity, are we even in a position to make a medium-term financial plan?
Well, I get your point, John. There could be massive changes on the horizon, but I think we still need to be looking ahead, because we don't know the outcome of that National Care Service yet. It does look like it's going to happen, but I think we need to plan as usual to the best of our ability. And I will be speaking to SIC and NHS about their own medium-term financial plans, and we'll be having a kind of collective discussion now the next couple of months to see what format that medium-term financial plan picks. But it's a good point, John, and it will be considered in the update.
Okay, it was just a case of making that point, and it's been made. Thank you.
Thank you. Gary?
Thank you, Chair. I think there is no doubt that there is going to be a National Care Service. What form it takes, I think, is still very much up for debate. But in terms of medium-term financial planning, I think the medium-term financial plan is only ever as good as the best information we can get to put into it. So I do think we need to continue with a medium-term financial plan using the best information that we've got. Otherwise, I think it makes annual budget setting even more difficult. At least if you have a medium-term financial plan behind your annual budget, then you can make adjustments to the budget. But not to have a medium-term financial plan at all, I think is a risky strategy.
Thanks, Gary. I would definitely agree. Do you want to come back, Carl?
No, thanks.
Okay. Any further comments, anybody, on this one? This was at the Audit Committee, so maybe go to Lincoln and ask if he wants to give us an update of how that conversation went.
Thanks, yeah, I'll take my hand down now. Yeah, we had discussions at the Audit Committee about National Care Service and the risk that could bring. So that was discussion and noted in the decision note. The other thing was around workforce and the concerns about the costs of supplementary staff and so on for the IJB, and that's obviously quite high in the NHS side. So that was added to the risk register for the IJB, and I shared that with the Audit Committee for the NHS on the 30th of November. And I think it's an issue facing SIC, NHS, and jointly the IJB. So whether that's a discussion that can be had around workforce development more widely and how we can maybe work together to try and not just encourage people to come to Shetland, but also the other side of it was about retention of staff having been through a pandemic as well, and ensuring that we're not losing good staff as well.
You seem to have lost your sound this end, Lincoln. I've gone on mute now. Hopefully we didn't miss too much of it there. John?
Yes, well, thank you for letting me come back in. And it really is just to state that I agree with what Mr. Robinson says, and also with yourself. Of course, we must have a medium-term financial plan based on the best information we have. And it was really just to highlight the point that we are in this rather invidious situation just now, whereby there's a considerable degree of uncertainty over the future of service provision in Shetland and other local authority health board regions in Scotland. And we've got a difficult task ahead of us, and it's an ever-moving feast. And I hope that clarity will come out from the Scottish Government in the not-too-distant future to allow us to make a realistic and sustainable medium-term financial plan based on fact and not on what-ifs. But thank you for allowing me to come in just to reiterate that and agree with Mr. Robinson and yourself.
Thanks very much, John. Okay, I mean, I think for me, there's no surprises in this financial monitoring report, which is obviously a good thing. We know the situation that we face at the moment isn't sustainable, but what we need to do as a IJB is to make sure we focus the spend on the areas that are our priorities. And I think going forward, the work that we're going to do in our new strategic plan means that we really have to look at how we use our money and use it to the best way we can to make the best outcomes for the community. So that does sit with us to ensure we make the right decisions. But we've been asked to note the management accounts. Are we all happy to do so? Yeah. Okay, thank you. We will move on to item 3, which is the planning and performance update. And I think Elizabeth has taken us through this one.
Hello, yes, thank you, Chair. This is the second quarterly update for the IJB, so performance up to the end of September 2021. We have included the normal suite of performance indicators and also 3 case studies, which is how we're planning to present some more qualitative feedback and performance overview on an ongoing basis. And then at the end of the pack, at the end of the report, I've included a schedule of potential case studies covering the next couple of years. We'd be really keen for the board to comment on any issues which they see as significant to either sustaining or holding back performance, and whether the case studies are the type of thing that you would like to see. What I'm also keen to do in terms of the case studies is to map them towards the outcomes that we're trying to achieve as an IJB. So I hope that this is seen as a work in progress, and we'll move more towards that sort of description of how outcomes are achieved on an individual basis, but also on more of a community basis. I'm sure there are other colleagues in the room who can help to answer any questions or queries that folk might have.
Thank you very much, Elizabeth. Does anybody have any questions on this report? I'll give people a moment. No? Okay. Any comments? Lincoln.
Thanks, Chair. Just really a comment on the case studies, which it gives you an insight into what work people are doing. So found it really interesting to read and Certainly, from my experience working in the Justice social work team, it very much mirrors the work that they do, along with people who are actually quite often traumatized, but also have had very difficult life chances, and certainly in a small community on an island, we need to be able to support everybody. So that was really good to see. Thank you.
Thanks very much, Lincoln. Yeah, and I think the way that we're shifting to show our performance in this outcome-focused way is so much more relatable to people. I think you read statistics and figures and tables, and I know it's important information and we have to have sight of that, but actually reading the stories about people's lives and the impact these services have on them is much more powerful, and I think it is definitely the right way to go. So I welcome this report today, and I think we're just being asked to comment, and I think we're all quite happy with that report, so thank you very much, Elizabeth. Okay, so we will move on to item 4, which is the winter plan for ensuring service sustainability, including the festive period 2021 to 2022, and I believe Brian is taking us.
Thank you, Chair. This is the annual presentation of the winter plan to outline how we're going to sustain services, provide resilience during both winter and the festive period. The plan describes health and social care provision, and it's been developed in partnership with the Health and Social Care Partnership, NHS, Shetland and SIC. So it's been developed to understand that it's a system-wide kind of provision of winter planning and resilience across all services. Plan is a dynamic process, so there will be emerging issues which will need to be dealt with, and the plan will need to adapt with that. There's also some sections still in draft, as there is a plan to hold some scenario planning in the next, well, prior to Christmas, to test the plan and put back any learning back into the plan that would be relevant. And I think that's the way the plan's always been. It's been a dynamic kind of process that allows anything that happens to be fed back into the plan as a bit of learning. Last winter we did cope well, but there were significant challenges, including managing a second wave of a pandemic, whilst also trying to implement quite an ambitious vaccination programme. So this year's plan has been developed, taking all the learning from not just last winter, but previous winters as well, and incorporating that into the plan. I think it'd be remiss of me not to say that we do go into this winter period with a system that's already quite hot. Workforce issues, workforce resilience, trying to maintain business as usual, with also managing a pandemic is still playing a part of the whole system. But just to say, part of our resilience and our planning is actually being able to flex services and workforce elements to ensure that they're locality-based, demand-led, and are focused on where they are most needed. And that is a kind of ethos we've taken right across health and social care as we move into the winter. Happy to take any questions, Chair, that may arise.
Thanks very much, Brian. Any questions on this one? I'll maybe kick off while people think about the question. There's quite clearly a lot of work that's gone into this plan, and as you said, there's still more work to come. It's quite clear that our services are under pressure at the moment. It's been a busy almost 2 years, and there's no real sign of that letting up. I suppose my question would be, we've talked a lot about winter pressures on the service. What can we do to help support ourselves and the people in our communities over this winter period?
Thanks for that, Chair. I mean, that's a very important point. The system does include the communities that are accessing services. So I think there's a real drive maybe this year to just be aware that we're still in a pandemic. So, having that awareness, adhering to guidelines, including, self-testing, not socialising if you have any symptoms, and just, some of the even more basic measures of that we've been getting used to over the last 18 months to 2 years. Hand hygiene, face coverings, those kind of aspects will, I think, go a long way to protecting not just individuals but the system as well. I think from a health perspective, if people are unwell, maybe trying to ensure that how to access the right professional, the right service that can help maybe for the symptoms individuals have. There has been a recent mail drop right across Shetland explaining about how individuals can access the right professional, the right conversation, maybe the use of NHS Inform or for information, or if people need to speak to someone, 111 by NHS 24, should be first ports of call. That aside, there are always emergencies that arise, which will, decant straight into accident emergency. But we're trying to allow the resource to be able to prioritise those cases, and anything else is actually accessing professional service. I think from a social care and social perspective, I think this winter in particular, we want to use all the strengths and assets we have in our community in Shetland. Friends, family, checking in with those who are maybe living on their own, or who have maybe additional support needs that are maybe exacerbated during the winter, and just ensuring that individuals are able to cope with whatever winter throws at them, whether that be winter or isolation or keeping warm, all those kind of really important kind of individual needs. Neighbourliness is potentially another one. Reach out to maybe those who need a little extra support within our communities. Just being that good neighbour, just by speaking to people, or breaking their isolation, or it's even the small things that can make such a difference. That's something that we've learned in the past. Is it could even be changing a light bulb, or just checking. Some of the heating systems now are so complex that even just checking the heating to ensure maybe some of our more vulnerable people are just kept well and are living well during winter, I think would all really be system-wide kind of preventative kind of activity that we all could take part in.
Thanks very much, Brian. That's really helpful. Anybody got any further questions, Robbie?
Thank you very much, Chair. Can I kick off by paying tribute to the tremendous work that's been done by NHS staff members as far as the vaccination rollout is concerned. I do notice that everybody's beginning to look a wee bit tired, and I'm just wondering, I note, and I may be treading into NHS areas here, I just wonder if consideration has been given, as in other health boards, to further recruiting appropriate persons and training them to relieve the pressure on NHS staff as far as the vaccination is concerned, because it looks to me like there's going to be a repetition of this every 12 weeks going forward. I can't foresee what the rules are going to be, but it certainly would appear to be that. So I'm just wondering, can we perhaps assist the professionals by giving them a wee hand?
Brian?
So certainly, I can answer that in the first instance, but maybe public health colleagues who are attending the meeting might want to just step in as well. I think you're absolutely right, Councillor McGregor, what you're saying about sustaining that vaccination programme. We are urging as many people as possible to come forward for boosters at the moment, because that is another way of protecting ourselves and our communities moving forward. But where we're going will probably be more vaccinations, more routine vaccinations. I certainly know the planning's been around how we deliver that, because you're absolutely right. That there are aspects of it that have been delivered within services, but I know that there's also been a workforce plan to recruit additional vaccinators into the fold as such, to actually take on that as a routine kind of system. So I know there has been some external individuals coming to be part of the programme as well, to add some resilience into the programme as well. But I think moving forward, I think that's something we need to establish on a substantive basis.
Thank you.
Okay, thank you. I think Susan's got her hand up if you want to come in.
Hello, yes, thank you very much. Yeah, Brian's right. There's a lot of work going on around how we sustain the service because it looks like we will be continuing this for a long time. We don't know yet about annual boosters or annual vaccinations, but that may well happen. So we are planning on that basis. We have recruited some new staff recently, healthcare support workers who are going to be trained up as vaccinators, and that is the kind of process and what is happening in a lot of boards to train up staff specifically for the vaccination role. At the moment, actually, our vaccinators, we're doing quite well. We've got quite a few agency staff, which is really good because that's sort of protecting our own staff somewhat. We're not having to work them too hard. We do struggle with other staff that are needed for the vaccination programme because there are a huge number of other people. It's not just vaccinators. But we're managing at the moment and the team are working really hard to make sure that we can deliver the service, but protecting our staff at the same time so that they're not getting too exhausted. And, you know, we've got really high uptake rates across Scotland. It doesn't always feel like it when we're doing it, but we have. And it's really good that the public's coming forward to get their vaccinations when we're asking them to, because that's not necessarily seen everywhere else. But I think, you know, it's a whole community effort which is producing the results. But we are certainly, that the workforce side of things, there's certainly a lot of work going on that, and we will have new people getting trained up as time moves on.
Thanks very much, Susan. I think that's really helpful, and I think I'll echo what Robbie has said. You are all doing a fantastic job. I got my booster last Friday. Hate needles, but it was really, really fine, and it was seamless. Walked in, got it done, and it was great. So I think you're all doing a super job. Do we have any further questions on this one? No? Okay, we'll move on to comments. Any comments? Ian?
Yeah, thank you. I would just like to ask a comment on that with the winter pressure that if through the IJB, if we could ask the people who are using the service or the public just to respect staff both in health and social care, you know, because at times, and just you know, examples where staff have to isolate, so we're not able to deliver services as quick as we can or as we used to. So just for the public to be aware that and the people who use our services, that, you know, that we are trying to deliver as hard as we can. But, you know, for example, yesterday, where teams had to go out and do over 30 swabs on, you know, people. So, you know, that then impacts on everything else. And social health and social care staff then have to isolate. So therefore, they're not there to deliver care packages. So we might be an hour or two late or a day late for doing things. But just so the public are aware that we are working as hard as we can and we are trying to do everything, but just to make sure that, you know, that we will get to people as soon as we can. And it's not, we're not doing it, you know, for any other reason that just staffing wise.
Thanks very much, Ian. I think those are really good points. I think it's clear that everybody is working as hard as they can across the system. But I think we need to recognise that this year has been really difficult for many people. And there's some families out there who are still feeling the impacts of the pandemic and they haven't been able to return to their services as normal. So the pressure that's added on them is just exacerbated at this time of year. I think Christmas can also put additional pressures on people. There's so much expectation for people to be happy and have this great Christmas. And actually, for some people, Christmas is a really difficult time. So I think we can all do our bit by maybe just being a little bit more thoughtful to others this year. Let's, like Brian said, support our friends, family and neighbours, and I'll just maybe try to be a little bit kinder to one another so that we can all get through this winter and hopefully put less pressures on our services. So thank you very much. We have been asked to approve the winter plan. Are we happy to do that? Yes. Nobody said no.
Happy to approve.
Thank you very much. Okay, now we're moving on to item 5, which is tackling health inequalities in Shetland. And Elizabeth?
Hello, and thank you, Chair. This report is one that was requested earlier this year for the IJB. As an organisation, as the two organisations in the partnership, we have lots of conversations about inequalities and health inequalities and what they actually are and what we could be doing about them. And I think the request was to understand health inequalities in Shetland in a little bit more detail and understand what some of the actions that we absolutely know would work in order to tackle inequalities might be. So the paper was written by Katrina Reid, who is our health improvement principal, and I'm very grateful to her for having pulled this together. All our strategic direction for the IJB, the NHS and Shetland Islands Council and the Shetland Partnership, they all talk about health inequalities. They all talk about reducing health inequalities. We absolutely know, for example, that if somebody is in temporary housing and don't know where they're going to be living next year, or if they have very low income or very insecure work, it's very difficult then to make positive health choices or positive health changes. So if you don't know where you're going to be living next week, to try and stop smoking is really, really difficult. And sometimes we need to look at securing that housing, building some stability around somebody or with them rather than doing to them, to enable them to then live a healthier life. So that's a very simplistic example, but we're really clear that all of those things that underpin being able to live a healthy life are just so important, and there are things that we can do about them. So so the report comprises a description of health inequalities, some of the information that we have in Shetland that describes those health inequalities. So we include things like poverty rates. So we know that 1 in 6 children were living in poverty in Shetland, compared to 1 in 7 in 2014-15. We also know that the COVID pandemic and economic downturn will have made things significantly worse for people. So I think that the figures that we have today will probably become worse over the next few years. We also know that costs are higher in Shetland, and the further you get from Lerwick, the higher they are. So what we are proposing in this paper is a number of actions that are shown, are evidence-based and have been proved to tackle health inequalities. They're fairly generalist within this paper, but what we hope to do with the approval of the IJB is to move towards implementation of them within service plans and directions and the new strategic plan from next year, so that we're really clear that any services that we deliver, the community development work that we do with communities, is all focused on the people who need the most health help and support, and will consequently make a difference to tackling those health inequalities. Thank you.
Thanks very much, Elizabeth, and thank you very much for this paper. I think it was me that requested it, and I appreciate that everybody's really busy, but I think it's actually a really important piece of work, so thank you, and thanks to Katrina. Any questions? Alex?
Hi Elizabeth, thanks very much for the report. I just wanted to bring up the issue of neurodiversity. So neurodiverse, divergent people, including people with autism and ADHD, do face discrimination both by our wider society and individually, yet they're not protected, as in being neurodivergent isn't a protected factor, a protected characteristic in discrimination legislation. Yet these people are disadvantaged. We know in Shetland, or I've recently found out to my interest in Shetland, that we have a far higher incidence of people, of autistic people, compared to the mainland. And certainly as a paediatrician, I've been surprised by the number of young bairns who are autistic who are coming through our service. And I suspect that there are very many undiagnosed adults with autism and other neurodivergencies in Shetland. And I wondered if any consideration been put to this this group of people. in terms of suffering or being at risk of health inequality.
Elizabeth?
Thank you. I think that's a really important point. And I suppose my feeling is that we should be treating absolutely everybody as individuals and focusing on what they want their outcomes to be. And I think by taking that approach, by having really good conversations, by really developing an understanding with people of what they want to achieve, then we help to move away from either increasing health inequalities or any sort of discrimination that might happen. So I think when we're looking at inequalities, we're not just looking at the you know, what's set down in law. We're looking at people as individuals, and I just think that's so important in terms of the way that we work.
Yeah, thanks very much. I totally agree, and I think having that sort of relational focus to our care as health workers and social care workers is really important. I also wonder, you know, in the Child Health Service, we got some really good training by an organisation called Autism Understanding Scotland, who are funded by the Scottish Government, which is an organisation run by autistic people. And I know that was university found to be really helpful in understanding some of the issues. And I wondered whether that might be a recommendation that could be made more available to NHS and social care staff.
Do you want to come back in, Elizabeth?
I'm absolutely sure we can look at that. If you want to forward on details, then we can take that into account. Thank you.
Okay, thank you. Lincoln?
Thanks, Chair. Alex and I have been involved with the same group around neurodiversity. So, I mean, certainly in my day-to-day job and looking back at Lee's report around people in the justice system, we work closely with people who are neurodivergent, care experienced and have convictions, and probably are the most at risk of health inequalities sort of in the younger population. A lot living in insecure tenancies, quite difficult to get into employment and very difficult to sustain it. So lots of things like that. Food is a huge issue in the food bank. I mean, is a godsend, but actually a growing food bank isn't a good sign either. And the other issue that is creeping in more and more now is around heating, and especially this time of year, and the cost of electricity, and you know, people not being in a position where they can negotiate their electricity supplier because they're on a key card and probably paying the highest rates and are the least able to afford it. So I guess those are all things that come into the conversations, but also what I was actually going to ask Elizabeth is this information being shared with the local employability partnership, because I think that's quite a key sort of driver for things going forward for those groups of people who will fit into that or fall into that category, to sort of get an all-round picture where things are for these folk. And I think Brian maybe has some involvement in that, but it's certainly something to look at in a more broad sense. And I guess what that will also do is help focus on the people who are most in need.
Elizabeth?
Thank you. Yeah, I think that's absolutely right, Lincoln. We've obviously just produced this report at the moment. Katrina and I have been invited to present it, and in fact I'll be away, but Katrina will go and present it to the Shetland Partnership next week. And then I think we'll agree with them what the next steps are. I think it's important to say that this isn't the only work around inequalities that is taking place. So there's lots of work that Fela Simpson's team within the local authority is leading on. And I think collectively various individuals within this sort of the strategic planning across NHS and SIC are linked into most of these organisations. So we have got links with employability and the employability pathway and so on. And I suppose it's about extending our reach and making sure that we're all doing the right things. I think there are some really interesting approaches that Katrina can probably speak a bit more about, like Housing First is one of them. So it is so important to support somebody to sort out their housing, because that and their food, as you say, Lincoln, and their income, because that provides more of a firm platform in order to thrive and develop. So I think this is just the start of a journey, and I hope that we can gather momentum and take in all the other elements as we move forward, and collectively have an impact in this area.
Thanks, Elizabeth. Do you want to come
Thank
back
you.
in?
Thanks, Chair. Oh, sorry. Yeah, yeah. Thanks, Elizabeth. I think mental health is a huge part of that. It's probably for young people that I come across on a daily basis, it impacts on their mental health more than probably physical health, but they ignore physical health issues because of the issues they have with their mental health. So it is a bit of a vicious cycle. So it's good to see that this kind of work's been done. Thank you.
Thank you very much. I suppose my question is maybe a little bit more general. So I think this report
We've lost you, Emma.
Elizabeth, is it the town hall that's frozen?
Yes, I think it must be. Yeah.
Hi, can you hear us now? Sorry, we lost everybody.
Yes, that's
We can
good
hear you
now.
now, yeah.
Thank you.
Okay, thank you. I'm not sure what we've missed though.
I didn't hear your question at all, Emma, I'm afraid.
That's okay. No, that's okay. I stopped talking because I figured.
Okay.
I suppose my question is slightly more wider, and it's, this is a really important report, as we've had really good discussions and questions on it just now. But how do we link this back to our earlier items, so the financial monitoring report and the discussion around finance and how we spend our money to get the best outcomes? How do we ensure that we take the learning from this and we embed this into our strategic plan and everything that flows from that? So how do we make sure that this doesn't get lost and then
Lost you again, Emma.
Oh dear. I think should we just wait for Emma to come back in again?
Hi, we're back again. If we lose it again, I think we'll just maybe, what will we do? Pause.
Pause for 5 minutes.
We'll pause for 5 minutes and maybe log out and log back in to see if that helps. So is that okay with everybody?
Yeah, thank you for the question, Emma. That's a really challenging one. I think that some of this approach doesn't cost money. It's about how we work differently. So doing a health equality impact assessment it's a piece of work. It's something that certainly the public health and health improvement team can assist with or advise on. And it is just about ensuring that all the strategic plans and the operational plans that we have are taking into account inequalities and not inadvertently worsening them, and if at all possible, increasing equality and equity. So when we're making decisions, have we thought about access to services? Have we thought about how to include people who aren't IT literate or struggle with connections, which rather relevant today? And are we clear that we're having conversations with the people who are most excluded, I think, to make sure that we're meeting their needs? I think there are also issues that we've certainly talked about in seminars and things like that, about whether we need to put more funding into prevention, and also whether we need to accept that to some extent we need to do less for the people who are currently managing okay, and do a bit more for the people who definitely aren't managing. So I think some of the discussion is about how we help communities who are able to look after themselves to do more to look after themselves, and that then enables us to put more either staffing or support or resources into people who are less able to look after themselves.
Thanks very much for that answer, Elizabeth. And I think that's where we need to get to, isn't it? It's about building that community resilience and then supporting those communities that maybe don't have that, and helping those individuals who really do have these health inequalities and see what we can do to lessen them. So I really welcome this, and I really do hope it is at the heart of our strategic plan and all the decisions that we make, because I think it's such an important area that we can't forget about. Anybody got any further questions? Any comments? Oh, Jim?
One thing that worries me is, identifying these people, right? Because a lot of these people that, are disadvantaged, etc., right, are very loath to come forward. Right? And I think we're going to have to sort of, work more with the schools and, surgeries, etc., trying to identify these people, right? Because I think we'll have a problem getting them to come forward on their own. Right? So I think this is one thing that we should start looking at as well, is, what's the best way of going forward and identifying people that are in greatest need.
Thanks very much, Jim. Susan?
Thank you, Chair. I think this is echoing a bit what Jim's just said, and also what Elizabeth was saying. And it's about looking at people who are in the greatest need and those who are actually managing okay. And I think we all understand that health inequalities, there's an underlying basis which is really nothing to do with health and care services. It's about much wider factors. But I think when it does come to services, we need to be really careful when we're looking at what we're delivering. And I'm thinking about, we generally do really well in Shetland. So at things like, for example, screening or immunisations, we have really high uptakes, but they're not 100%. If I think about something like breast screening, we've got maybe 85% uptake, which is really good, and that's really high. But that means there's 15% of women who aren't getting breast screening. And we don't know at the moment if those 15% are people who have who are health literate, they have read the information and they've made an informed decision not to be screened for whatever reason, or are they people that haven't been able to access the service or haven't been able to read the literature, or for whatever reason haven't been able to access the service, whether it's due to physical problems or due to the issues that Alex was describing before. So I think that there's something about really, and as Jim was saying, there's something about really understanding who are the people that need more help, more support, with their health or to access services. And I think that's where we really need to focus. And, you know, at the same time, we can't provide really personalised care for every single person that needs a service. That would just be unsustainable. So what needs to happen is the people that can access, the people that can look after themselves, maybe with a bit of support, as Elizabeth has said, need to be able to sort of get on with that. And we need to focus our attention on those that can't do that. Because I think there is a danger quite often that we provide a really good service, but the people who access it are the ones, you know, who are much more able to do that. So I think it's just echoing what other people have said, and where we need to turn our attention to, especially where we already have, you know, as I say, high rates of immunisation, for example, or high rates of screening, or good access to other services. It's the people who are not accessing we need to find out about and really support them with their health and to prevent health inequalities.
Thanks very much, Susan. That's really good points. And I think it's really evident here that everybody has the same views and that we're all on the same page with this, which is also really helpful. Does anybody have any further comments? No? Okay, but I think we've all said that this is a good paper and that we, I think, undoubtedly all approve it and the actions in it into the refreshed strategic commissioning plan. Are we all happy with that plan? Yeah.
Unanimously approved?
Yeah, I think so. Okay, so that's us finished item 5. I plan to take a quick break at the moment, just for 5 minutes. We'll come back, well, 8 minutes maybe. We'll come back at 11:05, if that's okay. Okay? Is that okay?
That's fine.
Okay, right, see you in a few minutes. Hi everybody, we'll just make a start in a moment. Can you hear us fine, Louise?
Yes, we can, thank you.
That's great, thanks. Okay, that's 5 past, so we will recommence with agenda item 6, and that's the update on the change programme for primary care. And Brian's taking us through this one.
Thanks, Chair. This is probably quite a nice segue, actually, between the end of the last conversation and report to this one. The last report introduced about some of the principles we were hoping to introduce about investing in services delivered within communities, collaboration with colleagues in community and voluntary sector, and prioritising activity which focuses on early intervention prevention. And the primary care change programme that's been happening will hopefully realise a lot of those principles. The actual report is a follow-up to a previous paper presented to IJB, which laid out the perspectives of the development of a primary care programme, and it identified 3 work streams for exploration. That was strengthening locality working and multidisciplinary teams, extending community services through a hub ethos, and improving long-term condition planning and management through implementation of the house of care model. The principles and priorities around the programme are really revolving around integration of services around needs of individuals and local communities, people accessing the right professional, the right pathway, the right place at the right time, asking really what matters to individuals and how they can live well, and having that individual focus, developing relational aspects and supporting individuals, which isn't without its challenges as being a bit of a cultural shift across health and social care, maybe having a different conversation with individuals, looking at sustainability of services and best use of new technologies and digital enablement and prevention and early action. The last few months have been focused on really a lot of data gathering, evidence and some learning and understanding the baseline of what we have across our system in Shetland, and identification of areas for some focused intervention and change. It's been establishing the conditions for change, and we've taken a whole system approach by involving as many people across really services and third sector just in some of that community conversation. So with respect to the 3 work streams, strengthening the locality working and multidisciplinary teams, we've taken an integrated whole system approach. We are looking at what right professionals need to be in these multidisciplinary teams right across health and social care and social support. So it's not really just about a health model, but also sort of social work being involved and third sector and the what needs to be in a modern day multidisciplinary team to support individuals. We've undertaken a week of care audit in a variety of health centres, looking at how we're utilising GP times and appointments at the moment, and that's still ongoing. And we've also looked at digital enablers, and we've had confirmation from National Services Scotland that they're keen to work in collaboration with us on our project to look at automation of Ask My GP referrals and how that can look to ensure that people are getting signposted and directed to the right professional rather than everything being channeled through a GP at the moment. So that's all been quite positive. With respect to the community-based services and a hub ethos, we've been scoping what a hub looks like and what that looks like in a local context as well as a Shetland-wide context, and that was certainly some of the conversation we had yesterday at our meeting. We're looking at what community assets we have, what the need is within localities, but what the actual assets and linking that to community-led support ethos as well. We've undertaken some community asset mapping, whether that be services or other strengths communities might be holding. Part of that's also been reviewing the directories. There's amount of directories of services and support networks in Shetland, and it's really just looking for the economy of effort of what needs to be in these directories, but more importantly, how people can link to them to get the network that they need. And part of that work has been scoping digitisation of the directories and social prescribing. And then long-term conditions in house of care, we've been undertaking a test of change in Scallowa. We've developed bespoke tools to support patients and reviewed our documentation. So our conclusions thus far really is this isn't really just a primary care transformation. It started there, but it really is about transformation of community health and social care. And tinged with that is the locality aspects of that. We question whether the locality-based multidisciplinary teams and how they work, is that the same as a local hub? And are they one and the same? And what does that mean from a local perspective? And we're just teasing out that kind of conversation at the moment. But also with us being a small system and resources being tight, is there a wider Shetland hub as well that people will need to access to give us an economy of kind of resources as well, and people accessing those resources? We've concluded that digital connectivity, or certainly digitisation, is a key enabler to a lot of this work. There's also a lot of assets and activity already happening in localities, so it really is some of that previous conversation, the previous report. How do we connect people who need these connections the most to the activity, support networks and services that they require? So the next steps are, we're undertaking a second phase of the House of Care test to change. 3 more health centres have indicated that they're keen to take on this model for management of long-term conditions within their patient population. We're going to use the Week of Care data to review business practices in primary care to see that we're using our resources most efficiently. We're, as I said, linking in with National Services Scotland to look at the automation of our referrals. We're drawing together a business case for that digital connector, that social prescribing functionality, and we're considering a test of change in a locality to test out the hub working, the multidisciplinary team working, and really linking in with locality kind of assets and how that would work. And also we'll be considering the health inequalities and impact assessment moving forward, again linking to our previous paper. So a bit of a long-winded introduction, but I think we just needed to highlight that there has been progress, and I think that's been really good kind of progress in setting, I think, the future agenda of what we need to do and where we need to maybe just focus the next stages of the programme. So happy to take any questions, Chair.
Thank you very much. Okay, so does anybody have any questions on this report? Not seen any online. I'll maybe just kickstart off on the questions. There's a lot of information in here and there's a lot in your update, but how do we ensure that we actively engage with the community in these changes to ensure that they understand the reasons behind them?
Absolutely, really important, and we had that conversation yesterday, and perhaps it was a bit remiss of me not to introduce that as a next step. So one of the next steps is to start to have a conversation with both staff and also localities about what this actually means, and building everything in collaboration with those that will either be affected by it or will affect the change. So I think that's a really important point, that we've got to that point where I think we know what we want to have a conversation about now, and it is about absolutely engagement and involving those important kind of conversations into the model building.
Thanks very much. Anybody got any other questions? No? Oh, sorry, Lincoln.
I think Jane's putting her real hand up as well. After that. Just Brian, I was wondering, we obviously this is another thing, I suppose, Chair, about making change will cost money to save money in the longer term, and I guess it's all these things that we're trying to deal with at the moment, with all this pressure for financial balance and all sorts of things that we're not able to do. I was just wondering, Brian, in terms of looking at engaging, are you thinking community councils as well? Because just when you're looking at localities and possible venues and things within areas, they might be a really strong ally in terms of knowing what's available and I guess sharing with the community what there is around and maybe what is required in different areas, because obviously it'll be different in different places.
I think that will be one aspect of it, but I think we're still just forming our thoughts. I think some of the sort of culture shift and the innovative thinking around that might just be also a trigger of how can we maybe change that conversation of how we're engaging as well. So there is that community engagement, but there's also that individual engagement as well. You know, what matters to people most about living well and that preventative agenda as well. So I think it will be maybe a mix of old models of how we've engaged in the past, but, you know, looking at maybe how we develop conversations on an individual basis as well, and then merging the two. But certainly that's just in conversation at the minute as we pull together. That's the next stage of that sort of communication and engagement kind of process or strategy or framework for this programme moving forward. But I think I acknowledge your point. It is important that we're involving those who can have an influence as well with maybe some of the messaging.
Yep, that's great. Thank you.
Thank you. And Jane, I believe you've got your hand up.
Thank you. Yes, echoing really what you, Chair, and Lincoln have said there, and also going back to Susan and Elizabeth's point, I think, yes, there's information, yes, there's, but it's also about knowledge, and I think we have to acknowledge that we have work to do in that. How can an individual get involved in making these decisions? How can we support you to be part of a strategy group, etc., etc. And the other thing is just that relentless, as Feely talked about it, the relentless focus on expert by experience. And I think Shetland wide, we need to do more around that. So it's yes, it's looking at the information, but it's, you know, knowledge is more than information, isn't it? And informed choices, Susan was discussing there. That's about knowledge, and we can't lose sight of that. So thank you. But it is certainly all, you know, moving in the right direction, definitely. Thank you.
Thanks, Jane. Yeah, they're really good points as well. Anybody else got any further comments? No? Okay, we're being asked to consider the content of the report, note the progress in the change programme for primary care, and advise the Chief Officer of our views. I think we've done all of those. So are we happy with that? Yep. Okay, thank you very much. We'll move on to agenda item 7, which is the Shetland Alcohol and Drug Partnership. I'm sorry, John, did you?
Yes, thanks for letting me come in. It's just a kind of afterthought before we enter into this item. I will have a number of questions at the end, but I think it's important for me to declare an interest that I am employed as the recovery advocate by Castle Craig Hospital Limited, which is one of the rehabilitation facilities that may be used by Shetlanders. But what I will do is that I'll avoid any questioning with regard to that particular area.
Okay, thank you for that. Okay, so this is the Shetland Alcohol and Drug Partnership Annual Report 2020-2021, and I think Wendy is going to take us through this.
Hi, thanks. I'll just apologise in advance in case you lose me. My internet connection has been shocking today, but hopefully I'll manage to stay connected. So thank you for inviting me along and looking at the Alcohol and Drug Partnership report. I'm not going to take you through the report in detail because obviously you've all had a copy of that, but I would just like to highlight some of the areas where the ADP have made good progress during 2021 and also the areas for improvement as detailed in the report. So areas Where we have made improvements are around the rapid response to COVID restrictions, ensuring continuity of care for those who access alcohol or drug treatment and harm reduction interventions, supporting the licensing forum to increase and broaden its membership, launch of the Recovery Hub and Community Network, increase in support for families, increase in recovery groups and communities, increase in naloxone availability under the Lord Advocate's guidelines, a dedicated housing support worker for people affected by substance use, and the implementation of the near fatal overdose pathway data sharing agreement with Scottish Ambulance Service. Areas for improvement, as detailed in the report, are around support for children and young people affected by their own or another person's substance use, expansion of harm reduction interventions, including naloxone provision, injecting equipment provision, wound care, and bloodborne virus testing, including lived and living experience in the planning and provision of services for individuals and their families, volunteering and employment opportunities for people with lived experience, online presence, and licensing in terms of protecting and improving public health. And happy to take any questions. Thank you.
Okay, thanks very much, Wendy. I'll open it up for questions. We've got Robbie next first.
Thank you very much, Chair, and thank you, Wendy, for a most interesting report. I noticed the Westminster government seems to be in a wee bit of trouble over the last few days. Maybe I need to go and lie down in a darkened room when I'm going to praise them. I was absolutely delighted to learn of the progress as far as drug addiction policy was concerned over the last few days. I'm starting to hear words like compassion and support rather than enforcement. Perhaps the enforcement part is for another forum and not for this table. But I can promise you, Chair, there is a question coming. Yeah. I'm interested in the word innovation, as we've touched on in previous discussions. So my question is simply this: can consideration be given to further engage with the Scottish Government to explore funding opportunities to assist with the treatment of drug addiction in Shetland? Thank you, Chair.
Wendy?
Yes, absolutely. And if we reflect back to the heroin-assisted treatment that was raised at the last IJB meeting, we have had initial meeting to look at that and to start thinking about how that would fit in a Shetland context, and initial engagement with the government too to start exploring that. Thank you.
Thank you.
Thank you.
Thank you.
I've got John next.
Thank you, Emma. And thank you, Wendy. A number of questions, most of them pretty straightforward. Page 133 of your papers, page 3 of the report. When will the ADP website be launched?
It's in the development stage at the moment. We were hoping for a launch pre-Christmas, which would have worked really well because we could have tied in our Christmas harm reduction campaigns. But unfortunately, the development side of it has taken longer than initially thought by the developers. So we are looking at the start of the new year.
That's brilliant, Wendy. Thank you for that. The second question, page 134 of papers, page 4 of the report. There are 452 likes of the Alcohol and Drugs Partnership Facebook page, which has a wealth of information. I reviewed it again this morning, as I regularly do. How would you propose to broaden its reach?
I think what we've done a bit of in the past is particularly around the Alcohol and Drugs Forum. We have tried to engage with other members of the forum to make sure that we're getting reshares on the post. I think probably what's maybe slowed the process down a bit is that our social media was not given the attention it should have done in the first part of this year due to lack of resources in the ADP support team. We are fully resourced now, and the social media is back on the agenda again, and if you're watching it quite regularly, you'll see that there's been a lot more posts recently. So hopefully with more interaction with people and more shares, then it starts to spread and we start to increase followers through that.
That's great, Wendy. And I suppose as members of the IJB, we can all take a lead and take a bit of that responsibility and perusing the page and sharing as appropriate. Thanks for that, Wendy. Question 3. Page 134 of papers, page 4 of the report. 2.3 asks, please provide details of education and prevention measures, services projects provided during year 2020, specifically around drugs and alcohol. Now, Wendy, in Central Belt Scotland, recognised recovery groups such as AA, NA, CA, Al-Anon and Alateen regularly visit schools. Will this be explored for Shetland?
It's not something that we've actually considered. There was a mapping exercise of education for schools and other young people settings undertaken a few years back, and we looked at all the commissioned services that the ADP would commission to deliver education, and that was done in collaboration with education services themselves. So we've done that piece of work, but obviously we're always looking to improve any education input that we're doing. What we are waiting for is the Scottish Government to compile an education package for delivery within schools, so that we ensure that the basis of education that's being delivered is equal across all schools. And so anything that is commissioned by the ADP or anything extra coming into schools, for example, AA, is a true enhancement to what's already being delivered in schools, and just ensuring that the base knowledge is there. But that is something that we can certainly look to consider when we kind of revisit the education provision.
That'd be great, Wendy. I'd appreciate that. And if you keep me in the loop with regard to that, so a number of contacts in the Central Belt that actually do go into schools from this various organisations, Al-Anon being particularly so, which is a 12-step support group for families that are affected by just another addiction. So if you could keep me up with that, I'd be really grateful. I think it could be a considerable advantage. We talk about shared life experience. There's nothing greater than those that have experienced addiction and into recovery. Next question actually leads on very well. Page 135 of papers, page 5 of the report. What progress is there on having lived experience representation on the ADP? Can we have assurance that this gap wouldn't exist in next year's report as it did exist in last year's?
Yeah, we've recognised that we do need to work harder to have lived experience on the ADP and indeed on the forum. And that's something that we're looking at. We're hoping that now that we have the recovery hub in place, and that has increased the expansion of engagement with lived and living experience, that is the kind of route in to making sure that we have that lived experience voice on the ADP.
Okay, so we should, that's follow on that next year that gap won't exist in this report then?
We'll probably miss a year because the next time the report comes, we're nearly at the end of this reporting year, if you see what I mean. So we probably will miss a year, and we've only had the introduction of the hub in the last year, and it's only really gathering pace now due to COVID restrictions and various other restrictions placed on us. So there probably will be 1 year's gap.
Yeah, I appreciate that. It was just timing and yeah, fair play. And just, but I kind that you're on it, and I'm grateful of that, Wendy. I know personally that you see that it's been very important, and I acknowledge that. Only two more. Page 135 of papers, page 5 of the report. It states that Public Health and ADP Coordinator are keen that more focus be placed on evidencing that applicants and licence holders can meet the 5 licensing objectives at the point of application and continue to meet these objectives in the operation of their premises. They will continue to engage with the licensing board on this. Now, As this is a reoccurrence of the same concern raised in last year's report, and I suppose this question isn't so much to Wendy, but can the IJB chair and the lead officer intervene to facilitate the necessary change?
And Brian?
I think it's something we would need to take out of this forum, just to have a consideration of that. But happy to take that off away from this meeting and have that conversation and see what we can facilitate.
Okay, if that could be an undertaking, I appreciate that, Mr. Chittick, and if you'd be as kind as to report back at the next IJB how that's progressed, I'd be very grateful. And I'm sure that would be of help to Mr. Robinson and to Mrs. McConaughey. A follow-up to that very same question. The chair of the licensing board attends all alcohol and drug partnership meetings, which is good. And they're there in their capacity as the chair of that quasi-judicial body. Now, in order to ensure that there is no conflict of interest and to meet the Scottish Government's objective of having elected members represented on all ADPs, is it time to create a separate elected members position on the Shetland Alcohol and Drugs Partnership?
That's probably a question for the wider partnership rather than myself and the chair as well. We do have the vice chair at the meeting, so she might want to comment.
I think that's quite a difficult question to maybe ask at the moment, John, and maybe isn't one that Elizabeth's got her hand up. Do you want to come in, Elizabeth?
Thank you. I think it's something that we would need to take advice on from legal. I think they'd help us work that one out. John, if that's okay. Yeah, it's not that we're not opposed to the idea at all. It's just working out the logistics of it.
No, I understand. And what I want to make absolutely clear is that this is not a criticism of the member that attends the ADP. I'm just being mindful that as we have to do as IJB members, we have to be, and we're often reminded that we have to be conscious of what hat we are wearing at what particular time and what particular forum. And the chair of the licensing board is there as the chair of that quasi-judicial body on the Alcohol Drugs Partnership. So therefore, does not have to open the remit of an elected member with that legal obligations. And that's why I feel that there's potentially a gap in the membership of the ADP to ensure public representation from suitably democratically elected individuals. And maybe Mr. Risa may still be in the meeting. If he deems it appropriate, I'd welcome any feedback. If he doesn't deem it appropriate for this particular time, then I'd be glad to hear from him out with the meeting.
Okay, I don't see Jan's hand up. Just rewinding slightly, John, on the item that you asked Brian to take away and feedback at the next meeting. Can I ask that he can feed that back in a briefing rather than at the next meeting? I'm just mindful that are quite busy, that's all.
Of course, certainly. And see, Mr. Rees has his hand up.
Yeah, go for it, Jan.
Yeah, thank you, Chair.
I can't hear you, Jan.
Can you hear me, Chair?
That's fine.
Yeah, thank you for the question. I'll try my level best then. I hope you can hear me. My first inclination is to say that, you know, a governance issue such as this might not necessarily be something that the IJB would be required to make a decision on. You might have an observation to make about a gap if you perceived there to be one, and the materiality of it suggested that it needed priority action in some way. I do recognise, of course, the fundamental point that Councillor Fraser is making about the many hats that elected members are expected to wear, and the licensing board is deemed as a separate entity from the council in terms of its decision-making role. So the potential for conflict is there, but in the same way as the councillor has identified, it hasn't actually manifested itself as a problem. So the question of whether or not it's a true governance issue, I think, needs to be looked at. And then from that, we can come back and a view can be taken as to where the right place would be to inject any advice that might be necessary if it's a gap that needs to be plugged. I'm just not convinced it's a matter actually of concern to the IJB.
Okay, John.
Okay, but my response to Mr. Rees is that I understand and I totally accept and agree that it's maybe beyond the remit of the IJB in that particular finer minutiae of that detail. However, it's the IJB that this report comes to. So therefore, I have to take the opportunity to raise it in the only forum that this report arrives at. With regard to it not being highlighted as a governance problem, I think the fact that we have within the report for a second year running, and I don't know if it's prior to that, that there's concern about what the licensing board has taken to the Alcohol Drugs Partnership for input, suggests that there perhaps is a governance problem and perhaps an independent party is required. But we can hold that discussions at a later date. But I'll be watching it.
Okay, thank you. Have you got any further questions on this report, John?
No, but thank you for indulging me for so long, and thanks, Wendy.
Thank you. I've got Alex next.
Yeah, thanks, Wendy. Yeah, I know there's a vast majority of Shetland adult population uses drugs and alcohol, and unfortunately, there's a significant proportion of our population that uses alcohol and drugs harmfully. And I'd like to thank you and everyone at the ADP for all of the important work that you do. And recognise that there are a number of innovations in looking after and providing care to people who use alcohol and drugs problematically that are in the pipeline, and that your team is under a lot of pressure to keep up with all of this. So thank you very much, and it was really interesting reading the report. I've got a couple of questions. First of all, about the licensing forum. You mentioned the 5 licensing objectives of the licensing forum, and I just wanted to ask, is promotion of public health a core responsibility of that alcohol licensing forum? That's my first question.
Yes, it is. So in England, there's 4 licensing objectives, and we have the additional 5th one in Scotland that is the promotion and protection of public health. And it's a really difficult one to meet or to evidence that you're meeting, because it is quite contrary to alcohol use itself. But being able to evidence meeting those objectives is what we believe would be really useful in terms of licensing.
I see Elizabeth has her hand up as well. Do you want to come in on that one, Elizabeth?
Yes, just to support what Wendy has said, really, at the moment, there's no real requirement, although it is absolutely one of the 5 licensing objectives to promote and protect public health. It's not really clear that licensing applications are required to demonstrate how they are fulfilling that priority at the moment. And we have asked in the past, and I think we'll continue to ask, for license holders or license applications to actually demonstrate what are they doing, not just to prevent harm, but also to protect the public health. And I think that would give us more confidence that that systems were actually in place.
Thank you.
Yeah, I just wanted to follow up on how can the ADP move to ensure that some of those aspects are taken on board by the licensing committee and license applications.
Elizabeth?
Well, it is the responsibility of the licensing board. Wendy and I both sit on the licensing forum, which isn't a decision-making body, so we can make representations to the licensing board. I hope I'm right in saying this. I'm sure Jan will tell us if I've got it slightly wrong from a legal perspective. but I think we would be really keen to see the licensing board just widening their emphasis a little bit and taking into account the really severe human harms that we do see, and thinking about what could they collectively do. And it might mean difficult decisions, it might mean unpopular decisions, but actually we're in the business of, that's what we're all here to do, is protect and promote public health. And I just think it's such a core responsibility.
Thanks, Elizabeth.
No, it's very good to hear that, and I know, like, we're just about to enter into a Christmas period where a lot of people will be using alcohol, hopefully in a safe way, but we know from experience and data that festivals like this do also come with a lot of the harms associated with alcohol. And I think it's really important that as people promoting public health, we're aware of that. It's really good to hear that representation, Elizabeth. Moving on, I've just got one more question about naloxone. So for people who don't know, naloxone is the antidote to opioids, including heroin, and really an injection intranasally or intramuscularly of naloxone for somebody who has overdosed on heroin is a very simple and life-saving intervention that can be made by people with very little training, and it's really, really good to hear that we are in the process of increasing the availability of naloxone. I've noticed as I've gone around Shetland, seeing defibrillators in every community setting, and this is a similar. We're dealing with a similar kind of issue here. And it would be good to hear from you, Wendy, as to what plans we've got to further increase the availability of naloxone in the community, given that we are seeing continuation of drug-related deaths, including deaths from opioid overdose, as is being seen in mainland Scotland.
Wendy.
Yes, thanks. So we have increased naloxone provision under the Lord Advocate's guidelines so that it's now available at the Recovery Hub. And what that has meant is that people who may not have carried naloxone themselves before, because it was seen as more of a specialised intervention only available from specified drug treatment services, it means that people are now regularly carrying naloxone. So we might not have it available in the community and visible like a defibrillator, but it is available to anyone in the community. So anyone who is likely to witness an overdose, so that could be absolutely anyone who has interaction with people, can carry naloxone, and that's something that we'll continue to advertise and roll out.
Thanks, that's absolutely fantastic to hear. Thank you.
Okay, thank you. We've got Lincoln next.
Sorry, Wendy, I'll keep it really short. It was around the children and young people and sort of how to support them. And I just sort of wondered, is there training that could be rolled out to organisations such as Open, Moving On, the Young Carers Group with VAS, people who are engaging with the young people on a regular basis to sort of support them, and I suppose support staff to support them. And I was also thinking about naloxone as well, if people working in third sector organisations who maybe don't have the confidence to get involved with naloxone, if there was some training rolled out as well around that. And I guess when you're looking at folk who aren't part of the system, i.e. social workers and so on, people might be more amenable to having those kind of conversations as well about the concerns they have in the first instance about themselves or family members. Certainly from my working experience, lots of concerns about young people using drugs very, very regularly, and also the debt that creates for them with drug dealers, which again can cause even more significant issues. So really happy to have a conversation about that in the future, just off this. Thanks. And you've done well, Wendy.
Thanks. I think I've got Elizabeth that wants to come in on that.
Thanks, Lincoln, for the question. I hope Wendy doesn't mind me jumping in. I think there's training for open staff and for other organisations who go into schools, but I also think we need to widen the conversation. So all children who have issues with drugs and alcohol are, on the whole, members of families or being cared for. And there is very, very little evidence. Sorry, this is something I wanted to come in response to John Fraser's earlier point about organisations coming into schools. There's very little evidence of the effectiveness of drug and alcohol education. What's effective is working with young people and their families on building confidence, on self-esteem, on developing decision-making skills, on being able to say no and to keep themselves safe in all sorts of different ways. And I think it's really important that we understand that we're not just talking about drugs here, we are talking about alcohol as well. So alcohol and drugs in combination are far more dangerous than just one or the other. And that we're talking about not just working in schools, but working with families and children, children within those families, rather than possibly an assumption that if we educate all the children, then this will be our issue solved. I think we need to recognise our responsibilities as parents and adults, and that children and young people are growing up with us as potentially role models. So we need to understand our own behaviours, our risk taking, how that relates to children and young people as well. Thank you.
Thanks, Elizabeth. Do you want to add anything to that, Wendy?
Thanks. Yeah, thanks, Elizabeth. I would just add, Elizabeth is speaking about children and young people maybe with their own substance use problems and what leads to that. And part of what leads to that is parental substance use issues, whether that's drugs or alcohol. So in relation to Lincoln's point about training, the ADP have offered training to a variety of people who come into contact with children on a day-to-day basis. So teachers, youth workers, people who are not specialists in drug and alcohol support, but people who just happen to be involved in children's lives. And it's important that people who are working with children day to day know how to recognise the signs of parental substance use and thereafter know how to support it. So we have done that bit of treatment, a bit of training, and we'll continue to do that. Thank you.
Thanks, Wendy. That's great.
Okay, I don't see anybody else with their hand up. We've been asked to note this partnership annual report that's been submitted to the Scottish Government. Has anybody got any further comments? No, we're happy to note. Oh, John.
Yeah, thanks for letting me come back in because I was waiting until the debate. Now, I think it's absolutely wonderful that we have the rollout of naloxone, but I think we have to kind of put a note of caution there, is that an overdosing heroin addict who is in isolation, as addiction often creates people to isolate, will be highly unlikely to self-administer naloxone. And that's why I hope that we continue to look at HAT and safe consumption rooms in order to keep people alive. Now, we also look at the number of drug deaths, and every drug death is absolutely tragic and must be do everything we can in order to avoid it. But I think what we often fail to see is what's every bit as bad is not the fatalities, but those that fail to live. There can be many that can go through a whole life of active addiction and fail to thrive. That is where we need to focus our attention. The prerequisite to that is stabilising an individual and keeping them alive in order to enter into that constructive dialogue to signpost them into appropriate modality of recovery that's suitable for that individual's needs. In response to what Elizabeth said before, I'm not looking at just the organisations coming in to talk about the perils of alcohol or the perils of drugs. That's important, and education is important, and she's quite right. It's about a more holistic approach, about raising self-esteem amongst the young people, giving them the emotional resilience and coping mechanisms and appropriate outlets in order for them to seek the appropriate care and support. However, just organisations such as Al-Anon, which focus on assisting people that are powerless over another's addiction, can offer that very support to the children whose families are affected by addiction. And there is actually, I'm afraid to disagree with Elizabeth, there is significant anecdotal evidence of that being of considerable value throughout the central belt of Scotland, of Al-Anon coming in and engaging with young people who are affected by their parents' addiction. I hope that we see things progress with regard to the HAT, with regard to potentially safe consumption rooms, and potentially with external, not paid for organisations being utilised to best effect to encourage people, one, to enter into a proven modality of recovery as recognised by the World Health Organisation, and also to provide suitable care to allow young people and other family members to be able to cope appropriately with the addiction of others. Thank you.
Okay, thank you. We've got Susan next.
Thank you, Chair. Yeah, I just wanted to make the comment that we've obviously had quite a long discussion here around the annual report, but it's just to remind everyone that, you know, this isn't just about the work of the Alcohol and Drug Services or the Licensing Board or any individuals or services that have, you know, alcohol and drugs as their main remit. This is responsibility of the whole IJB, I mean, the whole NHS, really the whole community. And I think it's about, whilst we absolutely have to focus on, you know, the specific harmful effects of alcohol and drugs and what we can do about that, there is the underlying issues around prevention. You know, why do people end up using drugs or alcohol harmfully and other people don't? You know, the issues around resilience, around the adverse childhood events, all those sorts of things that we know about that are sitting there in the background, and that we all have a responsibility to look at, to try and understand, to try and tackle it. It comes back again to the issues around inequalities, I think, as well, and which, you know, groups of people or which individuals are maybe excluded, maybe have greater difficulties, and some of those may, you know, that may result in drug or alcohol, harmful drug or alcohol use to tackle that, to deal with that themselves. Or it may be a vicious cycle that goes around, that you use drugs and alcohol and therefore you become more vulnerable, more excluded, and there's more inequalities for you. So I think it's just saying that, whilst, you know, this has been a really useful discussion, I think, and obviously it's focused around the annual report, that this is a much wider issue, and it is a responsibility of all the services and really the whole community to look at this, particularly around prevention and around supporting people who do have, you know, do have issues with this.
Thanks very much, Susan. I think that's really helpful comments there to draw this to a close, because it is much wider than just this report that we're discussing here. Okay, thank you very much. We will move on to...
Jane has her hand up, Emma.
Oh, sorry, I can't see Jane's hand for some reason. Go ahead, Jane.
Sorry, I've had to come in on my phone. I was just between appointments. Just picking up on that point about it being the responsibility of the whole IJB, absolutely. And I think it's that whole social determinants knowledge that I was really trying to get at, because when you understand that, then you're more able to have influence in all the different areas across Shetland, which then impact on the services that you're offering. But my question, Wendy, was the update of, you know, that we've had from Brian there on the change programme for primary care. From a IJB point of view, it's absolutely vital that you know, all the services are involved in that, because that is a significant strategic, you know, direction we are following. Can you just assure the meeting that you are involved in those discussions, because we want to hold on to what innovation and is clearly evidenced as good practice, but we don't want to lose that in a strategic change. Thank you.
Thanks. Yeah, I am involved in the strategic planning discussions and thinking more broadly about how we embed drug and alcohol priorities across everyone else's strategies and how it becomes a whole systems approach and not something that the Alcohol and Drug Partnership is trying to focus on singularly. Thank you.
Thank you.
Thanks very much. Okay, we will move on then to item 8, which is the IJB Business Programme and IJB Action Tracker 2021-2022 and meeting dates for 2022-2023, which seems like a really long time away, but it's come along quickly. And that's Brian.
Thanks, Chair. So this is just a routine presentation of the business programme for IJB. There was some confusion at Audit Committee, IJB Audit Committee, regarding future dates and where they will lie, bearing in mind we have local elections in May 2022. So what we've done is we've added the actual dates for the 2022-23 calendar and also included seminars on that. So I'm hoping members would find that quite useful in some form of planning ahead. The business still to be scheduled. There's 2 outstanding pieces of business. One is the Members' Code of Conduct, which I'm aware Jan Rees has had the correspondence from the Scottish Government about what that will entail, and I think it was too late for clearance, and it's still a bit of business that will be scheduled hopefully for the next IJB moving forward, as will be the draft strategic plan. I just note that the next IJB on the 17th of February seems to be a special meeting for accounts, but I've spoken to the Chief Financial Officer about that, and we're not sure about the accuracy of that. There will be some financial elements potentially put forward in that meeting, but the feeling was the accounts special meetings are normally around about June time. So that will hopefully mean that we can channel some more business through that meeting, Chair. The action tracker has been updated. Hopefully members will notice that there has been some progression against and completion of some of the actions on the action tracker. So we will remove those for the next presentation of the action tracker moving forward. Happy to take any questions or comments, Chair.
Thanks, Brian. I see Jan has his hand up, so you might want to come in and talk about the Code of Conduct.
Thank you, Chair. Yes, we could give you an update and I've opened the way for
We can't hear you very well, Jan.
Yeah, sorry. Yes, just to say that I have information update on the model code, and I thought it'd be worthwhile coming in just now before the Chief Officer takes questions, so that if the questions relate to that can be directed to me to assist Brian. Yeah, the model code came into being on the 7th, on Tuesday of this week, and on that date we received the information from the government, and the Standards Commission at that point had still not received the information directly about the approval of the code for councillors and also the model code. I think that they may have that now and it's on their website, but I'll send out links to members of the IJB so they can familiarise themselves with that. My intention, as the Chief Officer has indicated, is to report to the next IJB now that I have the material and the information to do so. What I'll also do, and then ahead of that meeting, is prepare an induction session and a briefing paper that I can provide to you and all your members about the salient points, and particularly picking up the changes, because there have been 1 or 2 changes that are quite significant for the public bodies that link to the model codes, and 1 change in particular in relation to the IJB and corporate responsibility. For example, there have been a few changes around registered and registerable interests and the effect that then has on the declaration of interests. And there have also been changes about the obligation of members of boards and councillors alike about the provision of private information supporting, for example, the register of interests that could give away and identify the address and so on members, and this is primarily because of the threats and so on that we've witnessed through the media in relation to members of the public officers and elected members in other local authority areas. So the code has moved in that direction, and there are some changes there as well. One thing I would say is that the board actually has a 6-month period granted within which to bring forward an updated code for your own local application. But my intention would be that, as well as notifying you of the changes, I actually produce a draft changed code for your consideration and hopefully approval at your next board meeting. And the advantage that would give is that that will enable me then to do a particular induction process for the new elected members of the council that may be appointed to the board and wouldn't have had any training or induction that I offer to you in January, February. So I'll do something specific around May and June in that regard. And that would be a good setting to give a really in-depth briefing for all members of the board, including those that are new at that time. So that's my planned and intended action, and we'll bring that that information into the business programme and tracker going forward. Thank you, and I'll take any questions.
Thanks very much, Does anybody have any questions on either that or the rest of this agenda for Brian? No, not seeing any hand. Jane doesn't have her hand up, does she? No. No questions. Okay, does anybody have any comments on this item? I think it's a fairly straightforward item. As we can see, we've still got some busy meetings to come up over the next few months, and I'm sure they will continue to be busy as the time goes on. Okay, if nobody's got any comments or questions, we're being asked to approve the business plan for the year and review the action tracker and approve the meeting dates. Are we all happy to do that? Yes? Yeah, I see Jane nodding. Okay, that's fine. So that concludes agenda item 8. So before we draw the public part of this meeting to a close, I just want to take a moment to thank everybody for all their input and their hard work in the IJB over this past year. I know it's been a really difficult year, but I think we're incredibly lucky here to have the officers we have that support us as an IJB, the members who sit on the board with us, and also all the people who support us in other ways, so committee services, legal. It's a really important role, and I do really appreciate every one of you for everything that you've done, and everybody who's working in all our frontline services and has done over this past couple of very difficult years. I just want to say thank you, and I hope everybody manages to have a reasonably peaceful festive, and we will see you all hopefully in the new year. So on that matter, we'll stop the recording of this meeting and we'll move into the exempt item.
Thanks.